Since I've given an opportunity to talk about research and all this kind of stuff, when I was younger, I used to think, that the world revolved around me and everything I did was important and all this kind of stuff. Then you get older, you realize that everybody else feels the same way. So the idea is that I could be talking about somebody else's work for the next hour and how guys like Brown and Goldstein won the Nobel Prize looking at cholesterol, and they found people have high cholesterol, the association with cardiac disease, and they went through an animal model. It was a rabbit that turned out to have the same sort of phenomenon as people, and I could give you a nice talk on that. But that's not my work, it's his work, their work. So I thought I'd talk about some of my own stuff because it's things that you can think about here clinically, and you'll realize that you see this sort of stuff every day, or certainly often enough clinically on rotations, on awards, or in clinics, and the question really becomes, how do you go from seeing something that's, a cute zebra to seeing whether it's actually a general phenomenon, something you actually get funded and study and work on? Okay, so you've heard of Lyme disease. There's some guy in Connecticut that saw a patient with Lyme disease and developed a whole career out of that. I was just started with one patient who had this infection from a tick bite. Somebody else developed a career on HIV. So you figure out, you can find a condition, a disease entity, and develop a career on it. And of course, really common stuff is the grounds have been pretty well plowed, so it's always easier to find a new phenomenon, but also looking at things that have been around for a while and finding your own little angle for it. We're going to talk about a phenomenon you see more commonly than you think. It's reversible myocardial dysfunction. It's basically people have weaker hearts. You measure ejection fraction, you find out that it actually gets better in a certain number of people, and nobody knows why. And in fact, until it's a technological kind of phenomenon that people used to measure heart pump function in a cath lab and with hemodynamic measures and pictures and all that kind of stuff, you didn't get to watch people over time very much. And so the general idea was your heart got weaker, you're stuck with it, And so it's sort of like a fingerprint. Somebody has an ejection fraction. You heard these numbers. The ejection fraction with somebody's a normal ejection fraction is basically people squeeze normally about 2/3 of the blood per beat. When it gets down to about 1/3 of the blood per beat, there are all kinds of physiologic things happen. Well, it turns out a lot of people reverse. And we know that only because technology is developed to the point where you can follow people serially. And you see people have weaker hearts, and they get better. And that we find it turns out to be in a lot of different conditions. We're going to be talking about one specific condition that is sort of a hotter topic or became more interesting to people. And that's related to sort of behavioral stress, emotional stress, and particularly the heart. This is, I don't know, from way back when, a good few years ago, but talking about the relationship between emotional stress and the heart, and people know that it's not good for you, and people know about arrhythmias. They've worked that sort of thing out a long time ago, that people can get palpitations, run into VTAC, or they get upset. So there's a relationship between the brain and the heart that goes way back to William Harvey made a statement about the relationship between the brain and the heart. So people know about it for a long time. But the question is the relationship between actual human behavior, human emotions, and the heart getting weaker and stronger is a relatively recent thing that people think about. Okay, so we'll talk about it in a minute. So here's an example of a case that came in. This is a number of years ago, but basically a homegrown case. 45-year-old woman was life flighted to Ruby. In 2004, she had these are not good numbers, okay? When your heart rate exceeds your blood pressure, it's not usually a good thing. Okay, so heart rate's 104, and the blood pressure systolic's only 88. So you generally think your blood pressure, your systolic, will be higher than your heart rate in general. Okay, she had what we call jugular venous distension. Neck veins were full of fluid, so you could see it bulging. You had noise in her lungs because the fluid's backed up into her lungs, and the heart sounds were kind of distant because it really wasn't beating very well. And he went to the cath lab. She had no coronary disease, clean coronaries, and ejection fraction of 10%. It's not a good number. People throw in, it's 5 to 10%. It kind of doesn't make a difference. The heart's kind of just barely budging. Normal's around 55, 65%. So it's much lower than normal. Sort of not really compatible with long life. Okay, and she's in shock. Okay, so she got through this sort of standard kind of stuff, which you tell people when you run a unit. You tell people basically, give everybody all the same stuff, and some people turn around, some people don't. So. She got all the standard kinds of things for temporizing her to keep her going. And bingo, she completely recovered, went home. All this happened in a matter of a few weeks. She had no prior cardiac history. Husband died in an ATV accident, and her echo a few months later was completely normal. So what's dramatic about it is you have people that are completely healthy, basically the kiss of death, and then they're back to normal again. Now the other conditions that are associated with reversible heart failure or reversible myocardial dysfunction have some other things going on with them usually. This is like the most pristine situation. No coronary disease, no hypertension, no nothing. Just simply the heart gets weaker, it gets stronger, and it's a very transient kind of phenomenon. And again, because of technology, you can keep people alive. Otherwise, people, if they died, you wouldn't know it's reversible, right? After you're dead, you don't go dig up the grave to see if the heart's squeezing. So the idea is, because of the technological advances, you can measure things serially, and you can keep people alive long enough for them to turn around. So the question is, geez, was this a freak thing or not? So around the same time, this is 2005, the paper came out in New England Journal of Medicine. When things hit the New England Journal, it obviously becomes a hot topic. The group at Hopkins looked at the same phenomenon, neurourinary features in myocardial stunning. Stunning was described a number of years ago, that in animal models, in fact. It was first described in animal models. You take a dog in a dog lab, you tie off an artery, and then the heart doesn't squeeze very well, and then you relieve the artery. It doesn't squeeze very well for a while, but it recovers eventually. You do it, you give it, even if you infarct a dog, you take a dog, tie off the artery, the coronary artery causes an infarct. The heart doesn't squeeze very well, but over time, relatively short, it can recover a certain amount of recovery even after an infarct. So people are aware of this. Basically, it was a dog lab phenomenon, in the 50s, okay, 50s and 60s. It was a dog lab phenomenon. They don't do it with people. They didn't see patients reversible, but it was called stunning in an animal model. And then it was found in other conditions, particularly ischemia. So what they describe in this Hopkins group is they took a look of people who came into the hospital, and if you look at the sort of the demographics here, mostly older women, okay, mostly older white, Caucasian women, whatever, and they had some risk factors, but they had clean coronaries, and within mostly 12 hours, 1 to 12, within the same day, they had some kind of traumatic event. And their blood pressures dropped, they had chest pain, and they had this kind of what looked like an infarct pattern. I'll show you in a minute. What's interesting, and this is something that's just, if you look at this, the heart rates weren't all that high, 109, 106, 108. If your blood pressure drops, you're stressed out, your heart rate should go up, but that's another phenomenon. In any event, you have people who have had some kind of stressful life event in a relatively short period of time, previously having no heart disease, having no coronary artery disease, and they completely reversed. And when they presented with this EKG, I don't know why they picked 4, 2, 16, and 18. That's like the British making up tennis, that crazy numbers you throw around. Anyway, I don't know why it's not 2, 4 in order. Anyway, if you look at this, these are flipped T waves. You see these waves? This is the QRS where the ventricle depolarizes. So electrical currents depolarize, discharging a battery. Electrical currents depolarize. When you repolarize, they should be upright. These things should be, so this is repolarization of the ventricle. It should be upright. And they're all upside down. Deep inverted waves, okay? Incidentally, the other place where you see this is with subarachnoid hemorrhage, or people have CT, have surgery, neurosurgery. You're not getting it. Okay. So you see this kind of deep inverted T waves, okay? So that's a sign of ischemia, of an MI, same sort of thing you're seeing in these patients, okay? But they're not having an MI, and they don't have ischemia. They're just heart muscle just got weaker. And here's this group of patients. You look at their ejection fractions way down here, and they go within a few weeks, they're back to normal. So here you see a group of patients that they collected at Hopkins who are coming in with the same thing we saw over here. Okay, it's an isolated case. And they followed these people, and they found, guess, gee whiz, they had reversible dysfunction. There's another study being done at the same time. Barry Marin, known for years, did a study in Minnesota where they had a group of patients that they followed, a larger number of patients, where they reversed, okay? And so the question is, geez, what could be a mechanism for this? In patients, there are a finite number of possibilities, so the easiest thing to do is draw a tube of blood, right? Draw some blood, make a measurement, look at things. So what do they look at? They looked at catecholamines. And if you look at the epinephrine, norepinephrine levels, they were really very high in these patients. They dropped lower. They were higher than patients in heart failure after an MI, and they reversed. Compared to normal values, they were just way up there. So you have an association now, not necessarily causal, an association between this group of patients who came in, who had some emotional trauma, hearts got weaker, hearts got better, and it's correlated with this observation that you have high catechols early on, the catechols go back down to normal, and the hearts get stronger. So that's at least a descriptive thing. That's the kind of stuff you can see clinically in a population and the kind of things you can look at in a study. So let me give you some idea what they see. This is I got a small model here, but basically the heart's, I don't know, small numbers, heart sitting in your chest like this, right? If you flip the top, this is the left ventricle, this is the pumping chamber. If you turn it on its side, okay, you see it squeezing this way. So this is the catheter in here, and you inject dye, and this is when the heart's relaxing. This is when the heart squeezes. So you can see that's an ejection fraction is based on the percentage of blood that you've expelled in a heartbeat. Okay? And you recycle it and measure it, and you can get numbers. Okay? There are different ways of looking at it. You can do that with an echo. You can do it with nuclear scans. But that's a heart that's squeezing really a good bit of the heart of the blood out per beat. This is what we're talking about. Somebody has a 10% EF. This is end diastole, end systole. It's barely budging. It's hard to tell one from the other almost. Okay? Those are the kind of numbers we're talking about. You see a little twitching. The heart doesn't really squeeze very much at all. You can't do that for very long without forming clots or basically dying. So that's a bad pump. This is what happens in this population of patients. Okay, a very distinctive characteristic. Here's the heart relaxing, and here it squeezes. It squeezes at the base, at this part of the heart, but not this part. Okay, it's called apical ballooning. This is the base, this is the apex. It's like you squeeze and a balloon pops out. Okay, and this is with an MRI. Okay, looking at the same kind of image. So that's sort of a peculiar phenomenon that was described, by the way, first by the Japanese. Before the Hopkins group, they picked it up from the Japanese. The Japanese described it as TAKOTSUBO syndrome. TAKOTSUBO is an octopus pot. That's when they catch octopi. Okay, it's kind of cute. You can see this in humans. You know, octopus are supposed to be pretty smart animals. Basically, they put food in here. The octopus gets into the beginning, gets through this orifice here, gets in, engorges itself. It's too heavy, too fat to get back out the top. And that's how you catch them. And they say, oh, what a stupid animal. I can't tell how many people probably do the same thing. You know, you put some food in here, they'd be in there and they couldn't get out. You know, so we do it to ourselves. So look at, I forget, I don't want to talk about obesity in this country, but you know what I'm saying. You know, this is an acute event for the octopus. That's not lifelong. Anyway, so it's called TAKOTSUBO syndrome. And now the Hopkins group gave it some sort of a potential mechanism, and so it became a hot topic in cardiology, still sort of is. And sort of the idea is, in a sense, you know, we have the amygdala in the brain, the hypothalamus, you get stressed, you get threatened, you have this sort of, your body gets turned on to these neurohumoral responses, and they have these set of mediators, and short-term, these are sort of these short-term adaptation kind of mechanisms, and long-term, they're damaging. And we know this, the classic for us, when I say us, I mean in cardiology, is heart failure, right? Patients who have heart failure, the heart's weaker, and you elaborate these chemical mediators, norepinephrine, epinephrine, you elaborate angiotensin II. Those mediators are elaborated. That's a correlation that was seen clinically, but experimentally you could show if you do something to those mediators, you can improve survival in an animal. People did this stuff in patients, and lo and behold, by finding out from animal studies, you can do the same thing with patients. If you block these mediators in patients with heart failure, they live longer, feel better, and you know, it's a whole different ballgame. All that stuff came from animal studies looking at causing heart failure in animals, showing these catechols are elevated, showing angiotensin II is elevated in animal models. Then the question is, if you intervened and reversed it, could it have an effect so animals live longer? Bingo, people are animals. Try the same thing in people, and that revolutionized the treatment of heart failure. I mean, it's really a big thing was in '96 when the paper came out showing that carvedilol improved survival in heart failure patients. And we have a guy here, Rob Ruffalo, who comes here periodically and was involved in this Wyatt research stuff, was really a really important player in that whole discovery, and it's revolutionized the care of heart failure patients. I follow patients with heart failure for years now, and we keep them going, and then they end up dying of cancer, which is sort of a really terrible thing. So I stopped ordering so many nuclear scans on people. You know, I start realizing you're giving them all this radiation and all this other, you're poking and prodding them, to leave them alone, they'll do better without all the diagnostic tests. So anyway, that revolutionized the treatment. The idea is short-term survival could lead to long-term disadvantage. So if you activate these mediators for short-term, it's okay. You know, if you're in a situation where you're out hunting and you get wounded, you go back into your cave, your wound is protected, you fight infection, you fight hemorrhage, you know, all this kind of stuff. So you have all these mediators in there, platelets aggregate, all those kinds of things that are good for short term. If you keep those things going long term, you cause damage. Now, the strange thing is, here you have people that got acute emotional stress within the same day, and the heart got weaker. So that's kind of a weird response to something which should be compensatory in the short term. So it's as if they get long-term decompensation from something which is usually short-term advantage. So it's sort of something to look at. So what are the features of this stuff? What are, the stress cardiomyopathy or TAKOTSUBO syndrome? Well, like something you want to use the term TAKOTSUBO syndrome. People like it because it's kind of fancy. You have an event, an emotional stressor. You have this highly reversible, most commonly in most postmenopausal women, and there seem to be catechol elevations. So the question is, geez, how would you study that thing? So one thing is you could take old animals, which we've done, and it didn't work as well. A lot of them just died on us. It took forever for these animals to get really old menopausal rats and this sort of thing. Don't knock it. It was anyway. Nobody wants to hear about all the bad things that didn't happen. So let's start. So the other side of it is you try something different. Particularly if you're in an institution that has laboratories. Okay, you want to have a place where you have labs running. And so if you have a phenomenon that you can find clinically, if you want to look for it and either want to establish a whole new animal model, or you look around and see what kind of models are available. Okay? And so the model at the time that was available was this Dale Burkle and what's her name? She's going to shoot me. Worked with another, anyway, she introduced us to their stress rat model, okay? And it was a prenatal stress model, okay? And this is what happens with this model. First of all, this is a Time magazine talking about first 9 months of this affect your life. So there's a whole field of study. Once you start looking into things, you find out what you're working on is related to all sorts of other things. And prenatal stress turns out to be a whole topic in its own right. And people talk about if you had bad few months of pregnancy, it's going to impact on the life of the whole child. And there are whole fields of toxicology developed around it. In any event, there's a whole field around this stuff. And we had one of these models here. And you have animals where you can basically take a pregnant rat, any mammal, take a pregnant mammal, in this particular case a rat, and you do something to the mother when she's basically third trimester of pregnancy, okay? Why the third trimester of pregnancy? Because that's when the amygdala, that's when the brain is developing, okay? These emotional circuits are being established in the brain of the animal. So you take the third trimester in a rat, which basically a rat's pregnant a pretty short period of time. It's not a long time, you've got a week, okay? So basically you're taking them and you're basically going to be stressing them, okay? So and one way of doing it, and the easiest way of doing it was just inject saline. You just take salt water to the back of the neck and you move the animal from cage to cage. So the mother's kind of refugee kind of situation, okay? So she's stressed out. It's all it takes. You don't have to beat her up and slap her around or anything. It's a very simple thing. You take her and you'll inject. We haven't tried actually without even injecting the saline, but you just irritate the mom and you make her insecure. You move her from one cage to the next and she's got to keep making up new nests because she's waiting to deliver. So instinctively, this is uncomfortable for her. It's a psychological stress on the mom, okay? And then they have these kind of effects that can predominantly affect how they respond subsequently to subsequent stresses. So the offspring of a mother who's been stressed during the third trimester of pregnancy, that offspring is sort of hyper-responsive to emotional stress, okay? So that sort of puts us in a situation where you have these women, even though it's much later in life, somehow they're not handling that stress that other people handle much better. Their hearts get weaker, okay? So the question is, what would happen to an animal model where their mother was stressed, they are hyper-responsive behaviorally, they're neurologically, their circuitry is set up where they hyper-respond to stress. Okay, because that's what we're looking for. So you take these rats, okay, you couple them, okay, amazingly successful in getting them, okay, to meet, and they have pups, okay. With the prenatal stress, the third trimester, 14 to 21 days, okay, you inject the saline and change her environment. She now has offspring, which we call prenatally stressed offspring. Those offspring are kind of like labeled, okay. And then what you do is after about 6 weeks of age, okay, 42 and 49 days of age, you can take these young rats and you put them in little restrainers. It's only a couple of hours. But if you've done this sort of stuff and you've actually done it and looked at it, it is really stressful for these animals. I mean, it doesn't, I mean, now I can tell you guys, but you put a rat in a restrainer, it's kind of, I don't know whether it's instinctive, it's the last thing you're obviously anthropomorphizing this, but it's like the last thing you would think of before a hawk would be biting your head off, is they'd control you and then bite your head off. So they're sitting there not happy, okay? So a couple hours of that, and they're stressed out. Their hair is flared up, and their eyes are changing. They're obviously emotionally stressed, okay? But you're not physically beating them up. It's all in their head of anticipation of what's going to happen, okay? A little anthropomorphic, because I don't know if they really anticipate what's going to happen, but whatever, instinctively, they don't like being restrained and not being able to move around, okay, for a couple hours. I don't think most of us would like that either. You know, if you had a lifespan of a couple of years, spend 2 hours at a time, it's like a good long, it's a bad weekend, you know. It's like somebody being in a straitjacket for a weekend. I'm sure it doesn't help us. Okay, so we wrote this paper looking at this particular enzyme, P38 MAP kinase, because that was sort of hot at the time. That's one of those enzymes that's part of the stress signaling pathway. You don't have to know all the details about that, but what's nice about basic science is that you have ideas out there, you have hypotheses on the shelf, okay? You got people studying prenatal stress saying that all the diseases in the world are related to prenatal stress, so you get that model, then you know that you have a hyper-responsive offspring, and then you say, okay, what could be the mediators of this kind of stuff? And there's a whole laundry list of potential mediators of this kind of stuff. And actually, we were among the earlier people looking at P38 MAP kinase in the heart, because you know, you don't have to, you just, there's a whole literature on that enzyme being turned on in the brain and other parts of the body. And so we wanted to know whether that enzyme was turned on in the heart and whether that contributed to this effect of weakening the heart and having it be reversible, right? We're looking for something, right? We're looking for some mechanism that we would say would explain that people have weaker hearts and they get stronger. And we have a potential mechanism in this enzyme that you can see in animal models whether that thing could reverse. That hadn't been shown yet. Okay, so we're looking at this animal model. And because of HIPAA, you can't identify the animal, right? So it's got little, you see the little red tips there? Okay, so you can't see the face of the rat. So you won't be able to identify. Okay, anyway, point, here it is. Its head's in here. It's under anesthetic. And this is an echo machine. It's scary looking compared to a little rat. But anyway, so when we think of echoes as being non-invasive, ironically, in animal models, when you do an echo in an animal model, they're anesthetized. You can't do an echo running around a cage. So we think of it as being a very non-invasive procedure. But here's what you're doing. You're actually sedating them and putting them in there. So what happens if you look at the hearts of these rats that have been subjected to stress? They have prenatal stress. They're kind of primed, right? That's sort of the second hit hypothesis. We can talk about it some other time. But basically the idea that you're primed to be hyper-responsive to situations. So you restrain them like a regular rat. And this is an example of an echo. This is an M-mode echo of a normal. Here's the heart squeezing, and here it's relaxing. Squeeze, relax, okay? These are heart cycles. Relax, squeeze, relax, squeeze. Okay, here it is after an MI. So this is a rat's been infarcted. It doesn't squeeze very well. See the distance between here doesn't get very, it gets bigger, and it doesn't squeeze very well. That's what an MI does, okay? What does stress do? Here's a control rat. Here's the difference between here and here. And here's a stressed rat. And you can see the biggest difference is over here that doesn't squeeze as well. Doesn't dilate, but doesn't squeeze as well. And one of the characteristics, you don't even know all the details, but one of the characteristics of reversibility is that when you reach the point where you dilate the ventricle, it's not likely to reverse. It doesn't squeeze as well, it may reverse more likely, but once it sort of dilates, it usually doesn't come back as well. So this is an example of an echo, an M-mode echo of a weaker heart that has potential for reversibility. So here in vivo, you do it enough animals, here are the controls, here are the stress, and they're weaker, okay? So the stress causes, you can measure the weakness in the heart, just as a result of restraining them. Now, the nice thing about animal models is you can take the heart out, right? So here's the heart in a little prep, right? And then you can study the cells. You can study the whole organ. You can study here little heart cardiac myocytes. Each of those little things are squeezing. And you put it in a machine, you can measure contractility, you can measure peak fractional shortening, and look at the difference. Here's a regular myocyte squeezing, and here's this myocyte from the stress rats, okay? So the actual individual myocytes are not squeezing as well after being stressed in this animal model compared to its control. If you use this inhibitor of that enzyme, it reverses. Kind of a nice thing. Geez. What does it tell you? It tells you, first of all, that that enzyme is turned on all of the time to make the heart weaker. And if you block its function, the heart can recover. So it's a really pretty good indication this may be a potential mechanism for continuing activation of that enzyme keeps the heart weaker. We need to turn the brake off, the heart can come back. And this is further evidence because here's what stress is. This is actual the protein phosphorylated, and you can see that in stress it's phosphorylated and you can block it with this inhibitor. That's all nice and fine. What about, can you really do this in vivo? In other words, if you take the animal, can you pre-treat it with this inhibitor and prevent the heart from getting weaker? So what do you do? Here's our cath lab. Okay, here's a little rat. He's hooked up. He's walkie-talkie. Ironically, in a cath lab in patients, you think, well, they're lying there and you got to do all these procedures. It's sort of very invasive. All the invasion was done before when under anesthetic. The animal's awakened. And now it's walking around. So it's actually ambulatory and physiologically much closer to normal physiology. It's walking around with this thing attached to it. Doesn't seem to be bothering it very much. And they're not under anesthetic. So you get a lot more information. And you get information from basically a cath. You're cathing the animal. You've got a transducer sitting in the heart. And you can measure what we call contractility, how well it squeezes and how well it relaxes. This is how well it squeezes, how well it relaxes. How quickly it squeezes, how quickly it relaxes. That gives you a sense of the heart pump function. Okay? Gives you a very good marker of that, which you can't do with an echo. Well, no, not really. Okay. And then here you have these measurements. With stress, you have decreased rate of squeeze, which reversed, or using the drug will prevent it from happening. And you have a problem with relaxation, same sort of thing. The drug will work to prevent the development of this heart weakness. And here's the same thing. The enzyme's here. It's gone if you use the inhibitor. And you can see it quantitatively. Okay, so now we got some sort of model. Looking at P38, it sounds like fun. Okay. Now literature comes up. Okay, you don't want to be, you want to be behind the time. So here's another Minnesota group, not the actual guys who wrote the first paper on Barry Marin's group at Minneapolis Heart. This is the Mayo Clinic. And the Mayo Clinic, I mean, if anything else, they got gall, okay? I'd use other words, but we're in mixed company. So the point is, it's cute. They missed the whole boat with this reversible dysfunction, okay? But in their paper, they described the Mayo criteria for this dysfunction, okay? So they weren't even the first ones to describe it. The Hopkins group described it. The Japanese described it before them. Now they got Mayo criteria. And anyway, so that they have the Mayo criteria for what? Apical ballooning syndrome, this whole thing about reversible dysfunction with emotional stress. And what do? Cute little paper. They looked at endothelial function and vascular responses to mental stress. So they basically said, well, are these people inherently different? And that was the same we said before. These prenatally stressed animals and mammals, are they sort of predisposed to exaggerated responses to emotional behavioral stresses? Okay, that's a question. I could ask that question in patients. So remember, anybody seen a movie? Okay, okay. So the same sort of, this little thing on his finger. Okay, so they basically did this tonometry, okay? A lie detector test, where you get this little device, and the heart group, Cardiovascular Research Center, is getting one of these, okay? And you put in any finger. It doesn't, I don't know any particular finger, but basically what it does, it measures the pressure, the changes in pressure, okay? With whatever you want to do, okay? So you can measure very subtle changes. Now people, of course, the microvascular folks are wild about this stuff, right? So, they've got a lot of microvascular people here. So this is what happens. I don't know if you know what Stroop, arithmetic, and spiral math. So these are stressors, okay? Now, if you're a mathematician, they may love this stuff. So they take all the geeks out of there, okay? They're talking about people, primarily postmenopausal women who've had MIs, and then you have this group of people that have this apical ballooning. So they had enough of these patients. Because Mayo Clinic's got incredible reserve of patient data, right? They've been doing this stuff long before anybody else. They track all the data. It's all in the computer, the kind of stuff everybody wants. That's the model, okay? Everybody in Rochester, Minnesota, I forgot the name of the county, but that county, Hennepin County, whatever, that county that they're in Minnesota, they got them all tracked, okay? And so they were able to go back and they looked at all these data. So they collected patients with these different conditions, and they gave them mental stress tests. Stroop is something you're familiar with. If you have a number, a word, and a color. Say the word is blue, but the color is green, and you look at it, and, you say, and they're giving you flashing these in front of you, and say, what color is this? And the word says blue, and the color is green. So it causes some kind of dissonance, whatever, and it gives people emotional stress. Math thing we all know about, you give them serial 7, 6, 12s, whatever, make them do math. And the spiral omnibus is it's like cross-examining somebody, keep asking them questions till they basically freak out. So these are stressors. Guess what? The people who have this apical ballooning syndrome have a very, very sensitive response compared to everybody else. So they are hyper-responsive. There's something going on with them, okay? It's not just that they have heart failure in response to somebody, some sudden bad news. They have a systemic disorder, something going on in their bodies that makes them respond differently, just like we talked about those animal models that we're dealing with. And guess what? Their catechol responses are up, okay? The ABS, the control subjects versus the epi, dopamine, norepinephrine, okay? Baseline, they're different, okay? They respond differently in their catechols, particularly their norepinephrine levels, okay? So their catechol responses are different. So how to look at this? Okay, so again, in basic research, there always, things are in or out. So oxidative stress is sort of an in thing for a while. And so what that refers to, basically you bite an apple, stick in a refrigerator, turns color, it's oxidized. The huge advances in evolutionary biology is that we have oxidative potential to be able to use that, to use energy. Oxygen is very important despite what oil companies may tell you. So the point is carbon dioxide in the air is a problem. Oxygen is what we depend on. In any event, this oxidative burst has sort of, if you think about taking a piece of wood, you have a fire, you put your hand over it, at the end of it, the combustion is there's water and carbon dioxide. We breathe out the carbon dioxide, we pee out the water. In the cells, okay, and then you have ash left there, right? There's some garbage in you, whenever you use charcoal or anything, there's something left. In the cells, there's some residual. The efficiency is not 100%, and when you generate energy and you use the energy in the cell, not everything is burnt completely, and there's little end products, and it creates, and we know chemistry is basically the transfer of electrons, and you end up getting some electrons that are not quite matched, and then they're free radicals, and they run around trying to mate with other electrons. So what you've got is an imbalance, okay? So you've got, the body's got these antioxidant defenses that keep the body from rusting from within or causing all kinds of damage, because these free radicals attack big molecules and big parts of the cells, carbohydrates, proteins, DNA. So you have these things that prevent that from happening. And so when you're looking at people who have hyper-responsiveness and increased catechols, it can create an imbalance, okay? If you have changes in vascular reactivity and ways your vessels respond to stress, one hypothesis would be it's related to the imbalances in how you handle this oxidative stress. So we wrote another paper, I've got to finish responding, but basically it looks like it's accepted. We just have to, famous last words. But anyway, they got good reviews, we'll get it in. So basically, we looked at an acetylcysteine because that's basically been shown to be a compound that helps this imbalance, okay? How does it help the imbalance? So if you use acetylcysteine, we can have an effect in this animal model. Well, we'll go through it step by step. First of all, you take the animal model, and we said catechols are elevated in patients with this disorder. So we took the animals, we measured their catechol levels in response to the stress. They're much higher than the control. So they're behaving like the patients in the sense that they have a high catechol response to this kind of restrained stress or behavioral stress. Now we want to show that they have oxidative stress. Their ATP levels are lower. ATP is the oxygen, is the energy that's being generated by this metabolism in the cell, and they are low. Okay, they don't have the energy levels that normal cells have. So what is in the cell, particularly cardiac myocytes, what sort of keeps this balance, sort of an intracellular buffer to keep the oxidation to keep things in balance, so you don't get these free radicals running around causing damage, like apples getting rusted. The cells don't rust from within. They've got these chemicals, okay, and the body makes this from amino acids, makes a chemical that basically converts some of these, see that little dot there? It's a free radical. It keeps that, gets it converted to water. Like I said before, water and carbon dioxide are sort of what you want to end up with. So basically it converts the stuff through converting this chemical, these dipeptides, these amino acids, okay? So this is, and then it gets regenerated. So what you have in the cell is this little thing called glutathione that helps transfer electrons to couple to other molecules to keep them from acting out. Okay? So as it turns out, in our cells, you can show, in these cells in these animals, you can show that the stress rats have a lot of this thing called glutathione in a state in which it's being used up a lot. There's evidence that it's being used up a lot. And it's in this form, and if you look at the ratio compared to the control animal, more of it's being used up to convert these electrons to stabilize the cell than in a normal cell. A normal cell has a certain amount of this stuff in a state where it's ready to convert these electrons, and in the stress rat, there's more of it being used up. There's evidence of being overused, okay? So it shows that, and the reason they have low ATP, and part of the other things is that they don't have enough capacity to neutralize these rusting elements, okay? These free radicals. They're using them up a lot. So one way of handling it would be giving N-acetylcysteine, which would give you more of this protective, more of this buffer. It would enhance the buffer. This is known in a lot of literature that if you give N-acetylcysteine, it can help generate more buffer in the cell. So you have less of this oxidative stress, less of the rusting kind of phenomenon. So we gave it. And lo and behold, if you look at how well the cells work a lot better with this stuff. So guess what? It looks like it makes sense that you're preventing the rust. You're decreasing oxidative stress. On the other hand, if you actually look at the measurements, it didn't. It really didn't change it. Adding N-acetylcysteine didn't work the way people think it would work. It didn't work through this oxidative stress thing. It's a different mechanism. Now we're going to other mechanisms in the cell, which is nice because you do this in cells. You can't do that in patients as easily. And we're talking about how the heart muscle contracts. And what we have had for a number of years, worked with Guy Salam at Pitt when I was over there, is that the calcium in the cell that regulates how the cell contracts, there's SH groups, these sulfhydryl groups can regulate how much of calcium is released. Okay? Now, I don't want to bore everybody with the details. I'm looking through the group here. I'm not sure everybody's that interested in sulfhydryl regulation of SR release channels. But the idea is that acetylcysteine can do something besides what everybody else thinks it can do. And one way of doing that is measuring with the cells, measuring the calcium release and the contractility. And one thing to do is give caffeine. You know, people drink caffeine all the time, right? Well, it's a weird thing about caffeine. It's unbelievably, you can do all kinds of weird things in a cell and in vitro and all that kind of stuff. People drink that stuff like candy, right? People drink coffee all day. I don't know, people are incredibly tolerant. Okay, I don't touch the stuff. I don't know how people drink, but okay. But you get a certain amount of it in chocolates and stuff like that. But anyway, over time, you become very tolerant to it. But the idea is if you want to empty out the calcium from inside the cell and have it release calcium, you add caffeine, it releases a lot of calcium. Here's the intracellular calcium goes up, and the heart muscle gets stronger. Then the calcium has gone out of the outside, and it gets weaker. In a stress animal, it's even more pronounced. So I don't want to go into too much detail on this because I think people are losing interest. But basically, if you give N-acetylcysteine to these animals, you can protect the release of calcium. Somehow, the calcium gets protected. So it's not just the ATP, not just the levels of energetics in the cell that's affected by by acetylcysteine. It's actually how the calcium is used in the cell. That's sort of a different way of thinking about it. Okay? And to go through, if you give an acetylcysteine after the caffeine has made it weaker, you can normalize. You make it closer to normal with caffeine. Okay, whether it's how quickly it shortens, or how quickly it relaxes. So those are the features. Same thing with the calcium levels. The contraction and the calcium are the same. So here what you have. So now we have a model that reversible myocardial dysfunction can be mediated, I say is mediated, okay, by a combination of oxidative stress, p38 MAP kinase, and sulfhydryl regulation of the SR calcium release channel. That's kind of because of looking at these animals, and because we started off looking at a patient and wondering how they can have reversible dysfunction, we know we can at least show in an animal model that you can cause reversible dysfunction by playing around with these components. Now, where does that take you? Well, one thing is, geez, you can get deeper into the ion channels in the cell and see how this stuff works at a more molecular level and see which exactly ion channels are involved by this acetylcysteine effect to cause reversibility. That's one thing. Or you can look at neurophysiology and figure what's going on in the brain that's causing all this stuff in the heart. You know, I mean, obviously it's all brain because it's all behavioral stress or whatever it is. The heart itself doesn't know what's going on. It's the brain the only thing that knows what's going on. And it's that awareness in the brain that's causing all these changes in the heart. So you can look at basic understanding of what's going on with the neurophysiology in the brain that can cause the heart to go this way. And then, of course, it's clinical. You can do observations. So you can look at other observations like they just did before with this business of measuring in these patients with the tonometry. You know, you can make other measurements looking at mechanisms in patients. You make other observations, or you can do interventions. Observations means you're looking to understand things at some level, which you can do clinically, not anywhere near at the same level as you can in animal models. But then interventions in patients, of course, are very useful. What does it mean by interventions in patients? Well, there are drugs that are being developed. These p38 MAP kinase inhibitors are being developed. I keep getting invited to China. I don't know why I just don't want to. Anyway, there's a whole roster of drugs that are being developed that work through this mechanism that we're describing, or other drugs that are going to be developed that are using these kinds of mechanisms. And the idea is to give it to these patients, or give it to patients who have this predisposition, or give it, the question is, how far can you generalize this? Are these phenomena that we're seeing, that we see in these older women, anyway, postmenopausal women, is that a phenomenon only related to behavioral stress in people otherwise healthy, or is that same basic mechanism part of the physiology? In other words, when people get reversible heart failure from any cause, is the same mechanism involved. So the drug that would work for these patients would work for anybody else. So these patients, a model for everybody is that these people have something that makes the heart get weaker that other people don't have, or do they have something that helps the heart get better that other people don't have? So that's, you know, those are important things to know. Are they missing something or have something? So if you look at it in a general context, this phenomenon of stunning and hibernating myocardium, this was described first in animals and dog lab. Hibernating myocardium first discovered in clinical, and then he went back and saw it in animals. That people who had basically weaker hearts got bypassed or stented, and the hearts got stronger. I can give you examples of this. I've seen clinic. I've seen this. I actually have another presentation of multiple cases of reversible dysfunction of patients between here and the VA with this stunning and hibernating. So you got anybody here who takes care of patients is going to see this kind of stuff. People had surgery, people have had ischemia, whatever, you're going to see this. Sepsis, if you look carefully, that was done, Joe Perillo was the one who developed this in the 80s. Patients are septic. If you measure their ventricular function, it gets weaker and it recovers after the infection. Stroke and CNS is a really interesting phenomenon because those EKGs, those flip T waves and all that stuff, you see that very commonly in subarachnoid hemorrhage. Thank God. I mean, I'm old enough to know when the hypertension was not as well controlled, people used to come in with that stuff. They'd be, the word expression, not very nice words, gorked out. You know, people would be basically down to brainstem function, and they'd be, you know, their ventilatory, it was just terrible. These are horrible, but their EKGs all had these flip T waves, very commonly had that kind of stuff, just like what they're showing. So high intracranial pressure can do that. Alcohol. Very good. If you want to know the classic for reversible heart dysfunction, people drink, they drink, the heart gets weaker, they stop drinking, the heart gets better. You can do it so many times. I don't know how many lives you have in a cat, you know, but basically you can reverse. The interesting thing with all of these cases is whatever the cause is, you keep them on the same cardiac drugs, the beta blocker, statin, ACE inhibitor, and all that kind of stuff. Idiopathic familial or viral cardiomyopathies. There was a study that came out in Journal American College of Cardiology last year. There are people on a transplant list, and they just collected patients who are on a transplant list had a recent viral cardiomyopathy who EFs were in the 20s. And they measured, they followed their echoes. Bingo, a very high percentage of them reversed. They just simply reversed. I mean, they're given the same old beta blocker and ACE inhibitor sort of stuff we give, and they reverse. So that's any one of these phenomena. Of course, behavioral stress is the most dramatic because it's so quick. And if somebody's completely healthy and completely sick and then completely healthy again, the brain does wonders. So the take-home message is this kind of phenomenon of reversible dysfunction. So we were looking at this particular model and this particular animal and this particular patient population. You can look at any number of patients, just pick it up and run with it. Okay? If you want to look at reversible dysfunction, that's fine. You look at patients, you see a patient with this condition, you start studying it clinically, characterizing it, you start collecting the data on that population, you can study it from a population basis. What are the characteristics of these patients and all that kind of thing. Clinically relevant, obviously this sort of thing happens and we don't know yet, and nobody knows how to predict who's going to reverse and who's not. Everybody gets all the same stuff, and some people get better, and that's great. But what about the ones that get better? Is that they got something the other people don't have, or they don't have something the other people do have? We don't know that. That's what animal models are for. Get an animal model, you have reversibility, and try to figure it out from there. You're not going to figure it out from patients. You're not going to drag their hearts out and measure their cells in a prep. So right now, and of course, future research is both on the clinical side and the basic side. So I think that's some sort of idea of what I thought would be fun to talk about for me anyway. I don't know about the rest of you, but I thought, you know, coming here, using up my RVU time, I figured I'd get something out of it. One of the big keys is don't get discouraged, okay? If you're really interested in this stuff, go for it. It's like, people who are happy can live in incredibly, unpleasant conditions because they're happy with what they're doing, they're excited about what they're doing, everything else sort of melts away. If you actually don't like what you're doing, everything becomes a big issue, okay? What's the temperature in the room? Oh my God, the carpeting. Oh, look at the windows. Yeah. And if you look at places that have really great research, places are not exactly the most, beautiful, aesthetically pleasing. People live in places, they don't have any windows, they don't know what day or night, but you're into it, it's in your head, and that's what's exciting, that's what's fun about this stuff, and it exceeds all the other hassles about what the IRB is going to say, I don't care. If you don't want to put up with that stuff, then you're not really that interested, okay? Let somebody else do it. But at least help the people that want to do it. And this is sort of an idea, this perspective from clinical to basic. When you look at stuff clinically, you want to make sure, obviously you want people dying, you want bad things to happen. So what you're thinking about when you clinically is what is the standard of care? You don't want to deviate from standard care, you want to do what everybody else is doing. Okay? That's not a good thing for a scientist, okay? That's called a hack. If you want to do research, you're doing everything everybody else wants to do. That doesn't cut it. So the idea is you have to think of things differently if you want to sort of step out of the box and say, okay, what am I going to do differently with this population or this condition? What am I going to look at that not everybody else in the world is going to see? What tools do I have? What population do I have? What kinds of things? What's available to me? That's a big enough pain to do things anyway. Don't try to make it more difficult by trying to do something that you rarely see at your institution or in your program. Golly, obesity, for example, okay? There's it's amazing. There's tons of fat cells. If you want to study fat cells, you can find them, okay? And the answer is they have a guy who does gastric bypass here. You can take tissue samples and study that. That's an example of something that could really make an impact. So the idea is it's how you look at it. It's not really the subject. And I think that's about it. Somebody just walked out, so that's the end of it, okay? Okay, thank you very much.